Addictive disease affects more than 10% of the population, and yet we only have 3,000 to 4,000 doctors who specialize in addictive disease. Nowhere near the number of physicians that we need in order to be able to meet the need, meet the demand. Now, there are a few ways around that. You can either stop the demand by getting rid of the disease, by making people better, by not having the availability of the addictive drugs. We're not going to do that right away. The other way of approaching it would be to very quickly have more physicians who specialize in addiction medicine. Well, that takes years of training, so that's not going to happen right away. And the problem is that the Affordable Care Act has, although it's been promoted as increasing access, what it increases is the number of people who can use insurance to pay for services. But the services are already full. It's as if you're given a token to get on the bus, but every time a bus comes by, it's full, and you can't get on. And you have your token, but you still can't get on the bus. It puts us in a very sensitive position because one of the things that we're seeing is going to be a demand for addiction treatment to come from sources other than addiction specialist physicians. And the question will be, will that treatment be good? How do we compare and contrast? Because there are undoubtedly some people who don't need to go to the addiction specialist physician. They could go to their primary care doctor, they could see a nurse clinician, they could see a social worker, they could see a counselor. But we don't know at this point what the differences are in terms of best practices or outcomes for each one of those treatment providers. And what we need to do, and what we're starting to investigate now, are these differences. How do we differentiate the outcomes from each group, and how do we segment the population so that those with the greatest need are the ones seeing the physicians, and those with somewhat less need but who will get outcomes that are just as good will see the other providers?
Well, there are a few ways in which ASAM is promoting some of the ways to improve access to treatment by improving the number of physicians who are trained in addiction medicine, as well as the physicians who are trained with some of the knowledge and skill base that make up the core of addiction medicine. So, for example, there are increasing numbers of residency programs, fellowship programs in training for addiction medicine. This will increase the number of physicians in the workforce who have specialty training, specialty expertise in addiction medicine. So that's one way. Another way is through general education of physicians in the issues of medical education. And here ASAM has, say at the med-sci meeting that we have annually, a large number of continuing medical education credits that are available for people who come to the conference, as well as people who access them on our eLive learning centers and can get the information at a later date through their computer and the internet. Finally, ASAM is a member of something called the CORE Collaborative, which is a group of organizations which are providing education about the use of long-acting opioids as a part of the REMS requirement for the use of those medications. So those are some ways that ASAM is working at educating physicians and helping to decrease that gap.